about a lot of the familial Mediterranean fever and all of these diseases that can lead to amyloidosis. So it's incredible how I tell the house staff that the story on a lot of inflammatory diseases and their impact on amyloidosis and et cetera is a story that's only about 20 to 25 years old.
Correct. Yeah. Yeah. Late bloomer in medicine.
Right. Late bloomer. Yeah. I like that. Late bloomer in medicine. Well, guys, we're going to go ahead and get started. It is my pleasure to, on this Thursday, for our Department of Internal Medicine, Roy Benke, grand rounds, to introduce our speaker. Our speaker is Joel Fernandez, who is an associate professor of medicine here in the USF Department of Internal Medicine in our Division of Cardiology. Joel is the heart failure section chief for our Division of Cardiovascular Sciences, Cardiology. I had the pleasure of meeting Joel on my very first call. So as an intern, I had Joel Fernandez, Terry Lavex, and Dan Parnassa as my senior residents on my very first night call here at the USF College of Medicine. It was at Tampa General Hospital. And so obviously you tend to always remember your first nights on call. And Joel was an incredibly humble, incredibly relaxing person to be around on that first night on call. And that's really, I think, defined Joel's career. To me, he brings about that compassion, that empathy, that humanism with his patients. And he's just an absolute delight to always deal with. After Joel graduated from internal medicine residency, he completed his cardiology fellowship here at USF. After a decade of being with LifeLink and with Florida Cardiovascular Institute, we were able to lure him back to the USF family in 2014. During that time, Joel has really stood out with his heart failure care, particularly in the Latino population, where he's given invited talks to speak about heart failure in that population. Joel has a passion for cutting edge of heart failure, and today is no exception with what he's going to present. So with no further ado, it is my pleasure to introduce my very good friend of many years and one of our absolute delightful, outstanding cardiology professors, associate professors, Dr. Joel Fernandez, to speak about TTR Cardiac Amyloidosis. Joel, take it away.
Thank you so much, Joe. That very gracious introduction. It made my day. I appreciate it. I feel the same towards you, my friend. Congratulations on everything that you're involved with. All right, everybody. It's a pleasure to be here. Thank you, Jennifer, for putting this together. And just sit back and relax, and let's talk a little bit about amyloidosis, which is a very important and meaningful condition nowadays. We have to be very familiar with it, how to approach it, what's involved, the pros and the minus. So I try to create something nice for you that shows some foundational concepts, but at the same time looking at the future and what's the way to approach it like a specialist, but with a few home take pointers so you can apply to your practice. And cardiac amyloidosis is a restrictive cardiomyopathy, right? It's a type of restrictive cardiomyopathy that results, the TTR, that results from what we call unfolding of of an abnormal TTR protein that ends up aggregating, forming fibrils that find their way to the heart and other organs. But predominantly, we're talking about the heart today. Find their way to the heart, deposits, and it thickens the heart, producing a restrictive cardiomyopathy. So what's all the fuss about, right? We were just, before we started the talk, we mentioned with Joe, amyloid is a late bloomer. We historically from the 1600s, there's been some reference and naming the condition with different terms. And amyloid is because in Latin it has to be, it's carbohydrate-like, starch-like. That's where the term amyloid comes from. From the 1600, there were the original descriptions, mainly in autopsies, of some organs that look weird. Even they looked like lardaceous, like fat and hardened organs. But not much could be done about it. The mechanism was not well understood. All the physicians, botanists, and chemists could do was describe it. Years went by, even a century, then they started checking more in the microscope and looking further into components of things. And we had a little bit more of knowledge. The Congo red stain was produced, and now it can be further identified and picked out within the tissue. But really, it wasn't until the mid and late 2000s that, at least pertaining to TTR, we didn't get a huge breakout in what happened. And what happened was 2016, there was a new, first, non-invasive way of actually diagnosing the disease. The disease used to be diagnosed mainly with biopsies, right? Obtaining tissue. That's still the gold standard nowadays, but now we have a tool to diagnose with accuracy TTR amyloidosis. This is major, groundbreaking. Along with that, for the first time, medications showed up and they were developed around 2018, 2019. One of them specifically for the cardiomyopathy aspect of TTR, the other ones for the polyneuropathy aspect of TTR amyloid, which is another common manifestations. We're going to talk about that a little bit. So why is this important? This is important because amyloid is considered a rare disease, but it is truly not. It's out there. It is prevalent with other conditions that are well known, like heart failure with preserved ejection fraction. It's about up to 15% of patients with HFpEF. What they actually have is amyloid, presenting as if it was HFpEF. And we're going to make a distinction in the next few slides. It's also important in aortic stenosis. There's a prevalence also close to 10-15% with TTR amyloid, and atrial fibrillation as well. Higher even prevalence of TTR in atrial fibrillation. So it is very pertinent. It's pertinent to think about this when we see these other common conditions. All right. So today, this is the overview. We're going to go over a little introduction to TTR amyloid. We're going to go over some molecular mechanisms. We're going to go over the phenotype. We're going to go over diagnostic evaluation and the current and future therapies. And hopefully that will give us a nice foundation. So we all know a little bit more today about TTR amyloid. So what is TTR, right? TTR is a short version. It's the easy way of saying transthyretin, which is the actual protein. Transthyretin is a protein that is made in the liver, mainly in the liver. It is also made by the choroid plexus, producing some TTR for the CSF. And it's also made in the retinal pigment epithelium to a smaller degree. But the liver is the main producer of TTR, and its role is that of a transport protein. It transports thyroxine and retinol. We think we know some. We don't know the half of it. The molecule is an old molecule. In human evolution, it is also shared by other organisms. So it probably has way more duties than being a simple transporter, right? But investigations are ongoing. be called prealbumin. So for those of us that remember the term prealbumin, right, I practiced several years ago using the term prealbumin, more in the realm of nutrition, critically ill patients and all that. Since the prealbumin is manufactured by the liver, it's been an adequate gauge of nutritional status or response of the patient. But we got a little bit more evolved, and now it's called by transthyretin. And this little scheme here, it shows, this is from the 1940s, just showing the discovery of prealbumin with this little bump present in an electrophoresis study of the blood protein response in tuberculosis, so related to inflammation. I thought that was a nice little cute finding for you guys, looking at a little history. And transthyretin has this shape shown here on the right. It's a tetramer. It is formed of 4 components, 4 monomers. They are linked together, and there's some space reserved within the protein just exactly for this transport of thyroxine and retinol. So a little bit about molecular mechanisms. The amyloid fibril is the end result of this process that we're going to go over on how the transthyretin protein, when it becomes abnormal, it aggregates and ends up forming an amyloid fibril. This fibril is the problem. This is what deposits in the myocardium, and it pushes the myocytes away. It causes restriction. It makes the heart thick. And also there's some degree of inflammation in the myocardium. So everything ends up with the fibril. It is a cross beta structure where it's pretty organized, actually, and it ends up forming like little ropes that are very hard with very hard tensile strength. In general, this is amyloid in general, the fibrils can produce intracellular disruption. It affects the energetics of the cells. It affects the homeostasis of the cells and the quality control mechanisms of cells. And it can be deposited in many organs or produced by many organs. Now we're talking about amyloid in general. The purpose of this slide is also to remind you that not all amyloid is bad amyloid. There is functional amyloid. Some proteins find a way to shift conformation between soluble natural state and insoluble states for the purpose of hormone storage, for hormone depot, like parathyroid hormone. Okay, and there's just a few examples. The skin pigmentation, there's a melanin type of protein that does the same. So not all amyloid is bad, some amyloid is functional. Now, if we go and hone in into TTR cardiomyopathy, this is the process, this is what needs to be done, because from this develops a lot. Let's go over from left to right. We have the liver, who's the main producer, right, of the TTR. It produces TTR as a tetramer, like we just said. What happens with the abnormality is that somehow this TTR separates, dissociates, either by a genetic abnormality in as a hereditary condition, or by what we call a wild type of TTR, previously called senile TTR, but now we don't want to offend anyone, and we call it wild type. So we go from senile to wild type. All right. And at the end of the day, the result is the same. The tetramer dissociates. It dissociates into monomers, and these monomers end up misfolding. Okay, and they clump up. They have no function in the body. The body doesn't know what to do with it, so it aggregates. It forms amyloid fibrils, and these fibrils find their way to the organs that are sensitive to it. In this case, with TTR, it would be the heart, producing restrictive cardiomyopathy and peripheral neuropathy as well. Then we can talk about the phenotype. The main point here from clinically based professionals would be to always have a high index of suspicion and based on the clinical pattern. So most common finding, right, we're going to talk about specifically now the cardiomyopathy, the restriction. What I'm showing you here is the two parallel stories. To the left, we have what happens with TTR amyloidosis. To the left. To the right, we have the story with AL amyloidosis, which is very similar. Different mechanism, but they share a common pathway of depositing these fibrils. And if we start with TTR amyloid, we already went through the story that it dissociates, it forms circulating monomers and oligomers. This will find their way into the myocardium, and they have direct toxic and inflammatory effects on the myocardium separate from the fibrils. Okay, these are aggregation compounds that are cytotoxic to the myocardium, and with that comes apoptosis and affects the contractility of the myocardium. Besides that, we have the amyloid fibril formation due to this dissociated TTR, which also infiltrates the myocardium, causing stiffness. In an echo, for example, it will cause thickening, very gross, obvious increased thickness of the heart. By making the heart stiff, it doesn't let the heart relax well, and you end up with your restrictive cardiomyopathy. The story is about the same with the AL amyloid, right? You have the light chains. The light chains will also involve the myocardium, and they will directly produce also inflammation and cytotoxicity, and they will produce amyloid fibrils as well, different type, but same mechanism, producing a restrictive cardiomyopathy as well. And it affects the contractility and it affects the relaxation. It is super important. It is crucial in our evaluation of patients with clinically suspected amyloid to exclude AL amyloidosis because of the high mortality that it portends in comparison with TTR amyloid, which is also of worse prognosis, but it's a more smoldering and prolonged course. The next few slides, we're going to go over the diagnostic process, but this is a point that has to be driven in the wards or in the office. Once we're thinking, I wonder if this patient has amyloid, next step is exclude AL, exclude AL, exclude AL, okay? Because they can present the same way. So let's imagine a case here now that we have talked restrictive and HFpEF proper. Let's imagine this case is a 73-year-old woman with 3 weeks of dyspnea, with hypertension, history of AFib, osteoarthritis, takes amlodipine 10 milligrams a day, Eliquis 5 milligrams twice a day, and chlortalidone 25 milligrams every day. Her blood pressure, mildly increased blood pressure, 143/88, heart rate 72, BMI 31 kilos, JVP about 10 centimeters, and lung exam is clear. She is not in AFib during the visit. She has an S4, and she has some edema, along with her history of dyspnea over the last 3 weeks. She gets an echo, and the echo shows an interventricular septal thickness measurement of 1.4. Your normal is 1. In a range, it's less than 1.2, the normal. Once the septum becomes 1.2 or more, we call it increased thickness or left ventricular hypertrophy. So she has mild LVH. The ejection fraction 60%. She also has mild aortic stenosis with a mean gradient of 16 and aortic valve area of 1.9 centimeters squared, and a right ventricular systolic pressure estimated at 40 millimeters of mercury. Right? So there's some abnormalities here, some risk factors, some symptoms, some clues. So what does she have? What is the diagnosis? Is it hypertrophic cardiomyopathy? Is it cardiac amyloid? It would fit the talk, right? Is it HFpEF? Is it aortic stenosis giving her symptoms? It's mild, so probably not. Is it pulmonary hypertension giving her symptoms? Well, usually regarding HFpEF, based on studies, there's a score now that you can use to justify your management and your diagnosis. It's called H2FPEF score. If we apply this score to this presentation, she's probably going to hit all the points or almost all the points. It's a weighted score, right? So you can see as far as history, a patient heavy is 2 points. If there's hypertension, there's 1 point. If there's AFib, there's 3 points. Elderly and filling pressures, which were not measured in this echocardiogram. So out of all this, she has about 8 or 9 points. Down here, down in the slide, you can see what is the probability of patient having actual HFpEF based on this score.
Yeah.
Right? So her score, it's high. Her score is high, 0.95 probability of HFpEF. I don't think that anyone can debate that, yes, she has HFpEF. Okay? Hypertension, older lady, obese, LVH. It's a pattern, right? Now, what happens if we change a little bit her presentation with the same echocardiogram? It's the same, but let's look at the nuances of the story and see what we can come up with. 73-year-old woman, now she has 3 months history of dyspnea. Also hypertension, AFib. Instead of osteoarthritis, she has a history of carpal tunnel and spinal stenosis. Her medications right now only Eliquis, and her blood pressure is 106/80, heart rate 72, BMI 25. JVD is about 14 centimeters, clear lungs, regular rhythm, still edema, and an S4. The echo shows you the same type of left ventricular hypertrophy, same EF, everything else the same. Now, what does she have? Is it still HFpEF? Can we think about amyloid? The funny thing is that if you apply the H2FPEF score, now with less indicators, but still some indicators present, she still scores with an 85% probability of HFpEF. And if we don't think about amyloid, and if we don't teach our residents or medical students about the history classic for amyloid, the pattern, the clinical pattern recognition, the light bulb is not going to go bright, think amyloid, and let's not assume it's just HFpEF, because the treatment is going to be way different. It's an opportunity missed for making a diagnosis, and probably a missed opportunity to make an impact in the patient's quality of life and mortality. Okay. The details about amyloid in this case. So this is a slam dunk suspicion, at least for amyloid. We don't know what the diagnosis is going to come as, but amyloid should come immediately to our suspicion if we get this history of smoldering, shortness of breath, or fatigue. Okay, it's a few months history. Carpal tunnel and spinal stenosis. In this context of cardiovascular symptoms, amyloid until proven otherwise. Okay? Carpal tunnel is a very common condition in the world, but it's when you start mixing it with the other presentations where amyloid flourishes in your differential. Spinal stenosis, lumbar spinal stenosis, compared to AL amyloid, it is a predominant feature of TTR amyloid. Okay, carpal tunnel may be for both. the blood pressure, she has a history of hypertension. Not uncommon, very common and very missed presentation is low blood pressure, low normal, or intolerance to antihypertensive agents. Why is that? Well, if you have a degree of restrictive cardiomyopathy, that heart will have a fixed stroke volume and a fixed, probably low cardiac output. The way for that patient to defend itself is to maintain a proper heart rate. Okay? If we blunt the heart rate or if we vasodilate the patient has a fixed stroke volume. They're not going to be able to augment that stroke volume. The patient will develop hypotension and will have fainting, which can be an initial manifestation of this condition as well. So we have to be very clinical astute, okay, and maintain this suspicion always in the background. Also, beware of the echocardiogram reports, because once the septum is thick, it's probably going to be described as left ventricular hypertrophy. And what happens with amyloid, with TTR, is not hypertrophy, is ventricular thickness. It's not an enlargement of the myocardium, of the myocyte. That would be hypertrophy, but it's increased thickness. So keep using your clinical judgment and suspicion and put everything together. Another point about HFpEF, it should be an exclusion diagnosis. Even though the initial presentation of this patient was a slam dunk, you say it has to be HFpEF. Obese, older patient, hypertensive, right? It has to be HFpEF. Yeah, it may be so, but the point is we have to go through the mental exercise of excluding the other conditions that can be present that can make the heart thick as well. For example, restrictive heart disease, such as amyloid, hypertrophic cardiomyopathy, valvular disease, right heart failure, some obstructive anatomy, pericardial disease, and high output heart failure. The good news is that most of these can be evaluated immediately with an echo, and an echo can give you the answer. At least it will steer you away from those things. But it's so important to go through the mental exercise of excluding these other conditions and not labeling the patient immediately as HFpEF when we see them. So otherwise, we're going to miss out on important conditions. Some clues against HFpEF would be not having the typical comorbidities of hypertension, diabetes, the fact of smoldering progressive symptoms over months, fatigue, shortness of breath. The younger the patient, the less likely they're going to have HFpEF. And if you see a relatively low QRS voltage, it tends to speak against true left ventricular hypertrophy from hypertension. We all probably learned this about amyloid now, that low voltage amyloid, well, don't count on it too much, okay? When it's present, it's useful. If it's absent, keep going with your clinical suspicion, okay? What we really look at regarding the EKG, the best value for it in the world of amyloid is if you have an echo with a thick wall, okay, and you have an EKG with a low voltage, that's discordant, that shouldn't happen, that raises your suspicion of amyloid. That's the best way of using it, if both happen. And just a last word about HFpEF. This is to show the point that upon presentation of quote-unquote HFpEF, it's important, once again, to maintain amyloid in your background. In this study, this was a Minnesota study evaluating patients with HFpEF. Granted, it was biased towards white population mainly, right? But the point is they divided population in two groups, about 1,000 patients, a little bit over that. And the question is, how prevalent is TTR in HFpEF presentation? Well, the group that went with clinical diagnosis only, physicians suspected amyloid based on clinical clues. Then patients got evaluated. What was the prevalence in that situation? It was about 2.5%, versus the other group of patients evaluated, which was, we're going to screen everybody that comes with HFpEF, and by screening means obtaining a nuclear imaging test that I referred to at the beginning. We're going to talk a little bit about that. It's a PYP imaging study. Okay, then suddenly your prevalence goes up. Okay, I'm not suggesting we do this in patients, okay, but it shows how the prevalence is higher than what we commonly attribute. Okay, there is a difference between male and female population, especially in the wild type TTR amyloid, male preponderance. And as far as age, also with the wild type, the older we are, the more prevalent the condition is, which happens with HFpEF as well. All right. So let's add some more clinical information here. It's all about pattern recognition. Okay, pattern recognition. TTR manifests itself in a few ways here. We've talked about HFpEF type of presentation already, heart failure. There's atrial fibrillation as well. And there's electrical abnormalities like bradyarrhythmias, conduction abnormalities. There's a higher prevalence of patients needing pacemaker as well. So if a patient has HFpEF, AFib, and a thick heart, and they've had a carpal tunnel surgery, they have lumbar stenosis, you have to evaluate for amyloid. The patient has had amyloid until proven otherwise. On the musculoskeletal realm, there's a history of carpal tunnel syndrome that many times precedes the cardiac presentation by a decade or more. Okay. The lumbar stenosis is pretty classic for TTR amyloid in comparison with AL amyloid. Trigger finger, it just helps you raise the suspicion in the right context. If the patient has cardiac issues, okay, or even neuropathic issues, the next question should be, have you had carpal tunnel surgery? Do you have lumbar stenosis? Okay, and you'll be surprised. Presentation of TTR with polyneuropathy as well, okay, either hands or feet. These patients that have neuropathy diagnosed with unknown etiology for years, try to dig in a little further into the history, they may have TTR amyloid. Neuropathy is more common in the hereditary version of amyloid than the wild type. And a presentation of autonomic dysfunction. There is the orthostatic hypotension or intolerance to antihypertensive agents. Be always on the lookout for that. Someone that was hypertensive, because they can coexist, right? Amyloid can coexist in a hypertensive patient. So if you have a hypertensive patient, which is very common, on medications for a while, and suddenly they become intolerant to their blood pressure, suddenly you have a drop, low blood pressure, think amyloid. That's an autonomic, a dysautonomic presentation of it. You can have the presentation of IBS type of feature, chronic diarrhea, constipation, and weight loss. Very common if we look at it. And erectile dysfunction, also like carpal tunnel syndrome, preceding the actual condition by many years. I'm going to show you pretty soon in another slide that shows this dramatically. So for the most part, these are the clinical patterns that you need to know and just apply them. At the end of this slide, to the right, it's information about the hereditary aspect of this. On this list of letters and numbers is a list of genes that are associated with TTR amyloid. From top to bottom, Okay, the genes that affect more, that present more the cardiac phenotype in red. And as you go down, you have the genes that present more as a neuropathic phenotype. And then towards the middle, you have a little bit of both. Okay, the important ones, actually, I may have it in the next slide. Yes, the important ones that we need to know is a V122I, which is more prevalent in the US, Black Americans. There's a prevalence of about 3 to 4% of Black Americans carry this gene. It doesn't mean that 3 to 4% will develop TTR amyloid, because we found out that the penetrance of the gene is not the most potent one, but nonetheless, under the right clinical context, we should think about this. It is prevalent enough, and it manifests itself mainly with cardiomyopathy, rarely with neuropathy. The other gene is a V30M, and that's pretty much endemic in Portugal. It presents itself with polyneuropathy. And we have the T60A, which is mostly present with Irish origin. And we have plenty of that in the Appalachian area here. I have a patient or two with T60A, and he's a male. His presentation was AFib and dysautonomia, healthy person. He's about 40 years of age, 50 years of age. He works. And after a year or two on Vindamax, now he started developing a little bit of neuropathy. And we're going to get him on treatment for that. And the other two important genes are the I68L and the L111M, not as common, but present. Okay, so this slide I like because it brings awareness in our history towards talking to the patient. This was an abstract presented 2022 in the International Society of Amyloidosis conference, and it is the wild type versus hereditary TTR prevalence of the pre-diagnosis cardiovascular and neuro signs and symptoms in patients. This was a survey. Patients that were already on the disease and treated, they were asked, hey, do you remember what symptoms you had before you were diagnosed, both for wild type and hereditary? And these were the answers. Patients on the left, patients with wild type TTR. On red are the cardiovascular symptoms. What are the most common symptoms? Well, at the bottom, shortness of breath and fatigue, swelling, heart palpitations, right? Dizziness, lightheadedness, and fainting. It all matches with what we've been discussing already. They're not specific symptoms. They can be symptoms of anything. So that's where the clinical suspicion and the pattern recognition comes into place to achieve an early diagnosis of this condition. If we go to the right and we see the cardiovascular presentation of patients with hereditary TTR, it's pretty much the same. Okay? A little bit different percentage, but the same type of symptom. When we look at the neuropathy symptoms for wild type on the left, if you go all the way to the bottom, look at the most prevalent one, erectile dysfunction. If we go to the right on hereditary TTR, we're going to see that as well as a presentation in the top 5%. It's just that with hereditary, you're going to have other more significant neuropathic symptoms of numbness and tingling. Bottom line, ask for erectile dysfunction, ask for neuropathic symptoms, even if the presentation is cardiac on your patients. We have to have at least a basic screening for neuropathy or dysautonomia. Same abstract, just to make another point, same patients were asked, how far back did you start with the symptoms before you get diagnosed and treated? Look at this, amazing. Even more than 10 years before diagnosis, symptoms in the wild type, neuropathy-related erectile dysfunction. Okay? And then as we get closer to the time of diagnosis, more symptoms appear because the condition progresses. The same thing for hereditary TTR. Okay, I think you get the point. Our diagnostic evaluation, what tools do we have? We have the echocardiogram, which is usually the first red flag, right? We have left ventricular increased thickness, okay? We have thickness of the septum. We may have aortic stenosis to some degree. And classically, when present, is a low voltage on EKG. So in this particular echo, with this degree of increased thickness, they should have high voltage in their EKG. There's no way this patient with that echo should have this low voltage EKG, except for having cardiac amyloid. We have other measurements in echo, biventricular hypertrophy. We do some diastology measurements that show restrictive pattern. We have biatrial enlargement, which is a big deal, and it's a way of the heart to compensate for the increase in filling pressure of the thick and restricted ventricle. And we may have a little bit of aortic stenosis. We may have a little bit of pericardial effusion. Also, now we measure strain, which is a kind of a measure. It's not an ejection fraction, but it's a measure of contractility that is load independent. And it demonstrates a classic pattern that we refer to as cherry on top, which is like, it means it's this little red picture at the bottom here. It's like a polar map of the heart. If we squish the heart and we look at it as a polar map, the only normal readings for this measurement occur at the apex of the heart. And that is because usually the apex of the heart is the last area of the heart to be involved with amyloid. Usually the basal portion of the heart is the one that gets involved at the beginning. There's also cardiac MRIs. The bread and butter finding is your late gadolinium enhancement, which is abnormal. LGE is here in the middle. The first picture is a normal patient. Second and third picture is a patient with amyloid. In the middle, you see the white in the basal portion of the heart. That's an abnormal late gadolinium enhancement. The bottom picture shows a diffuse transmural involvement. There's other measurements, T1 and ECV, that are useful for amyloid. There's some research into monitoring response to therapy. Now, what you should know about MRI is that it's not for clinching the diagnosis. It's not for clinching the diagnosis. You start the evaluation with an MRI because of the value that it has for cardiomyopathy evaluation, okay, and infiltrative disease evaluation. It may give you other pathology, but you don't clinch the diagnosis with an MRI. You start with an MRI and an echo, but you don't end the journey with an MRI, but it's a useful tool. And lastly, we have what is becoming now the diagnostic workhorse is your technetium pyrophosphate, or 99M technetium PYP, as we commonly call it. It's a very black and white type of test, literally. And it's what it measures is the myocardial uptake of pyrophosphate, which is a calcium binder, so to speak. Wherever there's calcium, this pyrophosphate, which is attached to a radioisotope, will go and attach itself. And that will give you the picture of where we have buildup of calcium. We do two measurements. We do a planar measurement, just like an X-ray. It will show you that if we look at the left here, this is a normal test. The first picture on the left, a normal test after injecting pyrophosphate, you see all bones. You see the sternum, lights white, and you see all the ribs. That's a normal test, right? It binds to bone. As if we find a patient that has amyloid, the classic finding is the one on the rightmost. You see now this cardiac silhouette lining up with PYP. Okay. In the same study, then we conduct SPECT imaging, which is this transverse fashion of cutting the heart, just like a CT scan. And we assign also a scoring system to this that goes from 0 to 3. 0 is to the left, is the normal. 0 means no uptake, or barely any uptake. And everything is in relation to the ribs. Grade 2 is uptake that is similar to the ribs. And grade 3 is uptake of the heart, of the cardiac silhouette, more than ribs. Okay, this is diagnostic for TTR, cardiac amyloid, after we have excluded AL. We have to exclude AL for this test to be useful and diagnostic. Why? Because AL can show up as mildly abnormal PYP as well. Okay? It usually doesn't light up the way that a very abnormal TTR lights up, but it does light up to a mild moderate degree, and you may call it abnormal. Let's treat the patient for TTR, and we totally missed out on the opportunity of treating AL on this patient, which, as you know, carries very poor prognosis. And how did we find this relationship between PYP and amyloid? Because it's not measuring the fibril, right? Well, funny enough, the PYP is a very old test. At some point in the past, 1970s, it was the test to diagnose myocardial infarctions because of the subsequent calcifications present in the heart. So it's the same test. Nothing has changed about the test. No technique, but we found a proper use for it now. And the reason why it lights up in the heart is because of microcalcifications. This is showing you that in interstitial TTR, this monoclonal antibody dye, it shows up presence of microcalcifications. To the right, there's microcalcifications seen in fibrous region of TTR, and there's also microcalcifications in AL at the bottom left. Now, it's known that the microcalcifications in AL in the myocardium are less than the ones present with TTR classically. But nonetheless, this can lead to an abnormal PYP. That's why in the process of the workup, it has to be evaluated. Now, I'm going to run you through this slide. We're going to try to get done here in 10 minutes. I'm aware of the time, but this is very meaningful. And where we start is with a heightened index of suspicion. Okay, we've talked about this through the talk. You have to look at pattern recognition, about the clinical presentation of the patient, about the risk factors, and about the cardiac, neuropathic, dysautonomia, musculoskeletal findings. Okay, if the light bulb goes off and you say, okay, amyloid, then you have to exclude AL. And we have to order free light chains, and we have to order immunofluorescence studies, urine and serum. No more SPEP, UPEP. No more SPEP, UPEP. You go with light chains and IFE. If that is negative, then we can proceed with a PYP. Okay? If the PYP is negative, I'm going now on the right side. If the PYP, this is the bone scintigraphy, is negative, keep following your clinical suspicion. There are some genetic hereditary transthyretin cardiomyopathies that don't light up in the PYP. It's the minority, okay, but it's present. So keep following your clinical suspicion. If you have a normal PYP, you may have to do a biopsy of the heart. But remember, most of these patients, a lot of these people are 80, 90-year-old people. Then we have to have a conversation of doing a biopsy in an elderly patient. We might have to do it, all right? The point is follow your clinical suspicion. And if the PYP is abnormal, then we do a genetic testing to document if it's hereditary or not. Why? Because medications that we're going to talk about next, there are medicines just indicated for the neuropathy aspect of TTR, and other medicines just indicated for the cardiomyopathy aspect of the heart. And the hereditary TTR tends to manifest itself a lot with polyneuropathy. Okay? And the other reason for doing genetic testing is for cascade testing and testing the family members with proper genetic education. So if we go back to our patient, now we drill the point, clinical pattern recognition drives the bus. What about current therapies? Well, we have the disease-modifying therapy for amyloid, which I'm going to show you next for both cardiomyopathy and neuropathy. But we also have the other battle of treating the HFpEF aspect of things and HFrEF aspect of things. And the ballgame changes totally. In summary, I'm not going to read the slide to you. In summary, HFpEF, there's not a lot that we can do. Treat with diuretics to get the patient the least symptomatically possible. These patients have a very narrow window of either passing out or getting congested. Okay? So we have to find a happy medium. If a happy medium means them not being short of breath and having a little edema, that has to be it, because otherwise, if we reach perfection in the fluid status, they pass out. With HFrEF, if we feel inclined to treat with something, okay, there's some evidence that the SGLT2 agents may be beneficial. It's not guideline directed in this condition, in this situation with TTR, but many times we try. Beware of the hemodynamic effects of volume loss and blood pressure with SGLT2. With the spironolactone MRAs, there is some beneficial information from a subgroup analysis from the TopCat trial that was a HFpEF trial, and it showed the benefit of spironolactone. Well, they looked at the subgroup analysis, and they found in a subgroup that was most likely amyloid, TTR, they tolerated, and it was beneficial in them. So I tend to use MRA as one of my first drugs, and then the diuretic of choice in GDMT. If the patient happens to have AFib, we have to do something about the rhythm, right? So then I may use digoxin. I may use beta blocker carefully, because it's well known that beta blockers may not be well tolerated. But if we have to rate control the patient, we have to rate control the patient. We try the beta blocker carefully with a very low threshold for stopping the beta blocker if we see hemodynamic effects. With AFib, we have to be aggressive. We try to ablate the AFib, anticoagulation all the way. When there's AFib, people with amyloid have high thromboembolic risk. Right now, the role of a watchman in lieu of anticoagulation, that's being studied. We don't know. In my patients, if they end up with a watchman for whatever reason, prior bleeding or something, I still keep him on anticoagulation if they can handle it. And finally, the last few minutes, let's go over the disease-modifying therapies. With this nice, pleasing slide, we go from left to right. What are we targeting with the agents? We can target three things. We can target the TTR production by the liver. We can target the stabilization of the protein. We can avoid the tetramer to become destabilized and misfolded and form fibrils. And we can also, hopefully, we don't do it yet, but hopefully we can get to target the TTR deposits to get rid of them, right? To degrade them. What we have on the left, TTR production. There are right now 3 FDA-approved medications, and they are called silencers because they silence the RNA, they stop the production of TTR to a significant degree, not 100%, but almost 100%. Very effective. Right now, they are only approved for neuropathic TTR. They are not approved yet for cardiac TTR, but hopefully soon we can hear from new medications about any indication on cardiomyopathy use. Those medicines are patisiran, vutrisiran, inotersen, and eplontersen. Weird names, I know. So those are approved for neuropathy. There's also been liver transplantation, right? If you transplant the liver, you have a new source of hopefully normal TTR. But now, since this medication came around 2018, 2019, the liver transplant is not the main option. It has inherent risks associated with it. And fun fact that you should look out for is the CRISPR. CRISPR, there's been a couple of successful studies in small amount of patients, mainly in Europe, of CRISPR technology being used for gene editing in hereditary TTR. Okay, so look out for that. Regarding stabilization, right now we have just two. We have three drugs really, but two FDA approved that stabilize that tetramer. One is our workhorse tafamidis, also called Vindamax, tafamidis, and a new one this year approved called acoramidis. It basically has a protective mutation of TTR that offers protection and prevents the tetramer to destabilize. Okay, the diflunisal is an NSAID. It has not been strongly studied, but in several small trials, it has some evidence. You know, I don't use it in general. Just you don't foresee keeping patients on an NSAID forever because of the inherent risks. But it's a tool that you can use temporarily on these patients, and you know you're not going to be harming them as long as you follow them closely for renal function and bleeding events. And then as far as TTR deposits, we have some monoclonal antibodies coming up in the pipeline. Regarding tafamidis, just a few words. This is the landmark study that led to the approval for the FDA. Look how interesting that the positive effect on survival came after a year and a half of treatment, which is not surprising because this disease is a smoldering disease. But there was mortality benefit, okay? At the end of the day, numbers needed to treat is about 7.5 to prevent one death over 30 months. And these are the phase 3 trials in cardiac TTR that are important. Attribute study is the one for acoramidis that I just mentioned. Something to look for is for Helios B study, which was a medication vutrisiran. It's a TTR silencer indicated for neuropathy, but in this trial, they tried it in patients with cardiomyopathy. The results were beneficial. We're waiting for an FDA approval. We'll see what happens, and maybe it's a subcutaneous injection every 3 months. So it doesn't get any easier than that. All right, my friends, I think that's all I had today. In summary, we got to keep a heightened clinical suspicion. We have to exclude AL first. And amyloid is a multidisciplinary type of condition. And remember, early amyloid clinic consult. Thank you so much for your attention. I'll be glad to take any questions.
Thank you, Joel. That was fantastic. Late bloomer disease with so many up and coming advances. And it's great to see you right at the forefront and USF cardiology right at the forefront. Very exciting. We'll take any questions from folks. We have a question for Dr. Ledford. Yeah, go ahead, Jen.
Okay, sorry. Dr. Ledford asked, do we know why the amyloid has proclivity for neurons and myocardium?
No, it's just something particular to the protein. There's particular for the protein. We don't know the answer. It's a property of the protein.
Get a great talk by Amanda McNamara comment. So I agree. 100% people have been texting me throughout the grand rounds how much they're enjoying this. Any other questions? I agree. Joel, this is just amazing stuff.
Yeah, listen, text me with any question. You're seeing a patient, you can text me. Okay, we'll help you out.
He is one of the nicest human beings I've ever met, and besides being an outstanding cardiologist. So I echo, please text him. We will love to answer your question. Well, we'll end here since it's 1 o'clock, and everybody have a great day.